Welcome back, doctors, ladies and gentlemen. I'm Val Johnson, the historian and a trustee of this society for a long time. I think there's only a few that have been involved longer than I. I'm glad to see you here. This is a great coming together of colleagues. This is a social event, of course, as well as an educational event. And for some of us who may have stopped learning and are on the other side of the curve where we're forgetting some of the things we learned once upon a time, the collegiality is a great part of this. I'm glad to see you here. We'd like to welcome now for this afternoon Dr. Kevin Erickson from the Baylor College of Medicine in Houston. Now it says on my sheet here, I've been instructed what to do. It says start clap. Okay, that's enough. That's enough. Okay. Dr. Erickson is sponsored by our Ogden Surgical Medical Society partner, the Kidney Foundation of Utah and Idaho. Please stand if you are associated with the Kidney Foundation. Somebody stand up. Okay, and then it says start clap. Okay, very good. All right. Dr. Erickson is an associate professor and director for clinical research in the section of nephrology at Baylor College of Medicine. He is also a non-resident scholar for Rice University Baker Institute Center for Health and Biosciences. His research focuses on health economics, policy, and outcomes in kidney disease. Please welcome Dr. Erickson. Did he say the pointer was supposed
I've got it.
Oh, you've got it.
Yeah, thank you. All right. Well, thank you everyone for sticking around this afternoon. As the title of my talk says, look this way. There's economic and policy issues affecting patients with kidney disease. And you're actually going to be hearing from me for the next 2 hours. I have this talk and then another one on kidneys following. So I hope everyone's excited about kidneys. I think there's a third kidney talk even after this, not mine, but if you can't get enough in the next 2 hours, you have a third one too. But this talk is really going to be about the history of policy and care delivery in kidney disease. We're going to sort of do a tour of history, and I was thinking about, why would this be interesting to general practitioners? I think first of all, it's just an interesting story in its own right. I might be biased, but it definitely there's a lot of policy that's helped formulate kidney disease for many years. But also, I think we heard this talk by the governor this afternoon. All the discussion about transformation of care delivery, value-based care. Policymakers have, for the last 15, 20 years, been increasingly taking a more hands-on approach to their involvement in care delivery. And as we think about what that might look like in all these other areas of medicine, it's worthwhile looking at kidney disease, where actually policymakers have been very hands-on actually for about 50 years now. And so I think there are some lessons that we can learn from this long historical viewpoint that can be applicable to when we think about what policy in other areas of medicine. So here's some disclosures. All right, so I can't see that side, I'll do this one. So 50 years ago, on October 30th, 1972, Richard Nixon signed the Social Security Amendments of 1972. What this did was created the end-stage renal disease program and extended Medicare benefits to people with kidney failure, regardless of their age. And so this was and continues to be unique in kidney disease. There's no other medical condition where you automatically qualify for Medicare based on your disease. What essentially it did was created a near universal healthcare coverage program for patients with kidney failure. So passage of this bill, we're going to talk a little bit about history. This was the accumulation of several different events, really in two broad categories. One was in innovation, and one was in political support. And so we'll cover both of these. I'll start with innovation. There were a lot of new technologies that were coming out in the decades leading up to 1972. One was kidney transplantation. The first kidney was transplanted in 1950. You can see here the physicians who did it and the patient. I think that one didn't last too long, and so if you Google when was the first kidney transplant, you'll actually see both of these appearing, and this second group in 1954 was the first transplant that actually led to long-term success with two identical twins. But so you had kidney transplantation coming out in the 50s as a way of treating end-stage kidney disease or kidney failure. And then you had innovation in dialysis machines. I think these started coming out in the 30s, 40s. I want to say 40s, but the technology was evolving. This is very old, early dialyzer machine. If we fast forward to what it eventually would turn into, this is more what they look like. But there was a continuous evolution in technological development in dialyzer machines. And then probably most importantly was vascular access. So this is the Scribner shunt. It was a device that could go in a patient's arm, and they could walk around outside of the hospital with this. When they need dialysis, come to a dialysis unit and have the blood access this way for dialysis. And this was the biggest thing, because before this, if you needed dialysis, you had to be in the hospital with a temporary catheter placed. So dialysis was something for acute kidney injury. It was something for emergency events. But this really enabled people to go and live life and just come in for these treatments. So by 1960s, between transplant, the dialyzer machines, and the shunt, it was now possible to treat chronic uremia with dialysis. Before this, when your kidneys failed from any condition, end-stage kidney disease, you were going to die from it. But the problem was it was extremely expensive, and so high costs really limited the access to this treatment for many people. So then we'll skip over to the political support that was going on at the time. So in 1965, you had enactment of the Medicare Entitlement Program, financing health care for the elderly. And after that, people were really excited about government making health care accessible to people, and there was a political movement to try to increase government funding for health care. Some people wanted a national health care system. Some people wanted just government involvement in different areas of health care. But people were thinking, oh, Medicare was great. What can we do next? At the same time, you had kidney failure as this condition that people were dying from because they couldn't afford the treatment. And so these two sort of different movements created conflicted with people's moral sentiments. They think government should be helping make healthcare access for more people, and at the same time you had people who couldn't afford their treatment for their kidney failure. And this, at the same time, was all brought to a head in 1962. Life magazine did a story on it was actually the first time I've heard it. Maybe people used it before, but the term death panel. And it was basically an expose on these groups that, if you had a dialysis program, again, there were more people that needed dialysis than could get it. You had these groups on a panel decide who's going to get the dialysis and who's going to die. And there was a lot of controversy about this. These groups were, in addition to looking at health characteristics, they looked at is the person an upstanding citizen? Do they have a family? So there's all sorts of judgments that came into place that created biases and controversy. So you have these two things: political support for more healthcare access, this kind of intense rationing that's going on. And basically between 1965 and 1972, every congressional body introduced a bill to expand government financing for kidney failure. They didn't pass, though. again until 1972. But in 66, an expert White House committee called the Gottschalk Report, or created the Gottschalk Report. And this also tried to estimate how big this program would be if you had the government funding dialysis, what would be the implications, what are the things we need to look out for, and called for this federally assisted national program to provide dialysis and transplant care. Interestingly, this report just grossly, by orders of magnitude, underestimated how much the program would cost and how big it would be. But ultimately, all of this culminated in 1972 to the passage of the end-stage renal disease program. Not a whole lot of focus on it when it actually got passed, because I think the presidential election was happening at that time. So we have the government getting involved in kidney care. This is almost 50 years ago. As we look through how the government and policy involvement in kidney care played out, I think there's sort of this concept that's important to think about. Most policies in healthcare, whether it's payment policy, value-based care, like we were talking about, or was being talked about this afternoon, they're trying to achieve this triple aim of providing access to care for people, trying to limit costs of care, and trying to improve quality. And just one thing to keep in mind, I've heard health economists say, usually a policy is good at attacking two of these things. It's hard to get a policy that can achieve all three. And so you got to pick, if your policy is going to attack two of them, say access to care and quality, then cost is the thing that there might be unintended consequences about or with. And so it's worth thinking about that with policy. I think that is one of the lessons that can be taken from all of this. So the first real policy achievement from the end-stage renal disease program had to do with access to care. ESRD program provided life-saving access to renal replacement therapy to a broad and diverse population. These are some of the early reports and growth in the program. In that top row, you see the growth with averaging 22% per year in growth and enrollment in the ESRD program. So these are people who would have died if the government hadn't had this program. So this is really an achievement, but it was more than the Gottschalk report predicted, and unfortunately, with growth in the program enrollment came growth in costs. And costs were going up, and by 1980, Medicare was spending $1.2 billion per year on its ESRD program. Again, a lot more than originally anticipated. So now we have, you're providing access to care, costs are going up, the policymakers in Congress act. And so they passed a law requiring that in 1981, Medicare bundle all payment for dialysis into one composite rate. So before that, you ran a dialysis treatment, you would charge on a fee-for-service basis, get paid for what you did, and the government says, no, we're going to just pay a fixed amount per dialysis treatment, regardless of what you do in that treatment. And that enabled them to really control the costs to them of the procedure. What they didn't do was include any way of adjusting for inflation. It had to be, I think, a law passed to actually adjust for inflation. So what you ended up having, even though the cost per treatment stayed steady, even though the cost per treatment stayed steady, after adjusting for inflation, actually the payments were going down for the next 30 years, payment per treatment. And so now you have a program attacking access to care and now costs. The other thing lawmakers did was, just as an aside, they created this Medicare secondary payer statute. So if you had private insurance when you develop end-stage renal disease, that private insurance would pay for your treatment for up to 30 months. Then you would switch over to Medicare, which has played a big role in financing of end-stage kidney disease care. But so yeah, like I said, now you have policies promoting access while controlling costs. Did they work? So if we look at overall costs in the program, they continued to go up. But interestingly, costs are on the left axis, enrollments on the right axis. They're going up in tandem, and so costs per patient are actually being fixed in this 30-year period. What's driving the programmatic cost is continued growth in enrollment and access to care. There was also, which we'll talk about later, the development of intravenous medications that weren't part of the bundle that did add to costs as well. But if you look at between 1975 and 2004, Medicare spending per end-stage kidney disease beneficiary actually declined by 0.6% annually, compared to the general Medicare population where it increased by 3.2%. So the bundled payments working, what it's not doing is controlling the issue of growth in the program. And to some extent, this is, again, a good thing. This is more people getting access to kidney disease care. So, why was there an explosion in the growth of end-stage renal disease during this period? Several reasons have been put out there. One is growth in the epidemic of diabetes, increasing hypertension incidence. This one's you have to think a little bit about, but there were improvements in treatment for cardiovascular disease during this period. So, you have to survive long enough to need dialysis, and before the 80s and 90s, patients were dying of heart attacks and strokes before they survived long enough for their kidneys to fail. So now you're preventing the death from heart attacks and strokes. More people are living long enough to need dialysis, and that's one other driver. And then this dialyzing sicker patients is something we've observed. And then also patients are living longer on dialysis, which causes growth in the overall program. So some of these, this growth is not, necessarily bad. But I did mention the intravenous medications that came out. So in 1991, the FDA passed erythropoietin, which is a medication that stimulates the production of red blood cells, which is anemia is really common in people with end-stage kidney disease. Before this, they needed to get regular blood transfusions. Now you had a medication that would keep the blood counts stable, but it was outside of the bundle, and actually dialysis units typically would pay less for this medication than they got reimbursed, and so they would make profit by giving more of this medication. And so they kind of caught on to that, and this became a big moneymaker for the dialysis unit. So even though their payments per treatment are going down over time from the bundle, they could make up for some of those losses by giving more EPO. And this rose to the attention of lawmakers and government regulators. The GAO report in 2006 outlined all of these issues and described the increasing use of ESAs. This chart just shows, ESA dosing from when they first came out in 1991, and basically essentially doubled by 2006. And, during this time, there were also starting to be trials suggesting that these might actually be harmful for patients, especially in chronic kidney disease. And so a lot of concern that we're over-delivering these medications, potentially just to make money. So what happens? Congress acts again. In response, and they, in 2008, passed the Medicare Improvements for Patient Providers Act, requiring CMS to expand that original bundle that initially just paid for the dialysis procedure to now include the expensive injectable medications that were previously separately billable. And so once something becomes part of the bundle, all the incentives shift. Now the dialysis providers have incentive to give less of it because they get paid the same amount whether they give more or less. And so that was the intent of this, was to really stop that growth in ESA use. And essentially what we see is it worked. The policy had its intended effect. Not so much on the percentage of people getting EPO. We see in 2011 when that policy kicked in, it starts to go down. But the EPO dose in 2011 really went down a lot. Now it started to go down before, again, because some of these studies were showing that they might be harmful. But it really wasn't until 2011 that we see a sharp drop with the bundled payment. And so once this went down, the Congress said, oh, well, CMS is now paying too much for EPO because the use has gone down. And so they changed the bundle and reduced payments through the bundle. So ultimately, these decreases did factor into fewer or less payments for the government. So, we've talked about trying to attack costs, trying to bring access to care, how there were some successes in the bundled payment program to control costs, but that programmatically cost growth did continue. So if we go to like 2016, we were in a situation where despite all of these efforts to control cost, you had 1% of Medicare beneficiaries with ESRD, but it's accounting for 7% or $35 billion of total Medicare spending. So there were still problems with cost despite these efforts. We'll shift, I mentioned if you kind of have a policy attacking two of these issues. The third one is a concern. In this case, it's quality. You had 30 years of policies focusing on controlling costs and access. People thought, what are providers doing in order to cut costs? And so almost immediately when the bundled payment program came out, you started having opinion pieces and people raising concern about quality of care in dialysis. So these are all articles that came out in the early 80s, again, right when this initial bundled payment came out. I kind of like this last one about the new medical industrial complex, which is what they were using to describe kidney disease care. But definitely concerns about quality throughout the 1980s. And this culminated in an Institute of Medicine report in 1991 looking comprehensively at quality in kidney disease care. And they really called for improvements in quality, improved mechanisms for monitoring quality, for helping people to, encouraging people to deliver higher quality care, and led to a whole bunch of initiatives. Practice guidelines came out of this IOM report, so that previously there weren't practice guidelines. They commissioned all of these studies using kind of harnessing CMS data that was being generated just through the routine practice of care. CMS was collecting all of this data on care delivery for almost everyone with kidney disease. And so these efforts came out of this quality initiative to harness that data and do studies on things related to quality, like dialyzer reuse and home dialysis. I don't know if any of you have heard about the Fistula First initiative. This was a big initiative to get fistulas in patients as a way of accessing dialysis instead of catheters, which are much better. And this happened over 15 years. They started giving report cards to dialysis facilities on their performance in different quality measures, implemented a certification process, and created these things called ESRD networks that regulate quality. They're local organizations that kind of manage these report cards and facility certification and an effort to improve quality. These are just some of the large databases that have been harnessed to help monitor quality in dialysis after that IOM report. So if we fast forward about the time when the bundle was expanded to include injectable medication, so 2011, 2015, by then there had been 20 years of efforts to improve quality in dialysis. There were still big gaps though, and so just to give some examples, I mentioned catheters. So if you don't have a fistula or a graft in your arm, you have to use a tunneled catheter to get dialysis, which puts you at risk for life-threatening infections. And if you look at the United States compared to other countries, we were actually pretty high rate of people starting dialysis. 45% of people starting dialysis with catheters, much more than a lot of other rich countries. So despite these efforts to improve quality in the Fistula First initiative, we have a lot of people starting dialysis with this sort of suboptimal access. Home dialysis, a lot of patients benefit from home dialysis. It helps them to keep working, it helps give them flexibility in their day-to-day life. But yet in 2012, we're sort of at the bottom of this list of peer countries in terms of the percentage of patients who are starting home dialysis. So again, the quality efforts hadn't panned out in this way. We still ended up, still have very high mortality in hemodialysis. This is a 5-year survival rate, where we see 5-year survival worse than a lot of cancer diagnoses. And so there's definitely potentially improvement to improve things like mortality and other aspects of patients' health. And then finally, disparities have been a big issue in dialysis. Probably the biggest one is actually here before dialysis. So these are people, chronic kidney disease, who develop end-stage kidney disease, where we see a much higher rate of incidence of end-stage renal disease among Black patients than all other races and ethnicities. Other areas with disparities, home dialysis, kidney transplantation, there's also big disparities that have persisted. So what did policymakers do in response to that? I think the response to these ongoing gaps in quality basically got enveloped in this broader initiative that you all are now a part of as well, which is the initiative to transform healthcare delivery and bring value-based care to care delivery in all areas. So in 2015, the Secretary of Health and Human Services announced a goal of having 90% of all Medicare fee-for-service payments linked to quality or value by 2018. This is just an example of some of the early value-based payment programs that came out of this initiative. The Affordable Care Act also was sort of one of the big instigators of all of these programs. But these have continued. Initially this was sort of came out of the Affordable Care Act, but in 2015, MACRA was a law that basically gave bipartisan support to this idea of transforming care delivery to value-based care. So, every area of healthcare is now seeing movement to value-based care, and all of the efforts to solve these ongoing problems in nephrology got swept up by this tide. So here we just see a timeline of all of the different value-based payment programs that have involved hemodialysis, end-stage kidney disease. A bundled care is sort of I would consider it a form of value-based payment program. So this goes all the way back to 1982 with that initial bundled payment program, but we start seeing more coming out in latter years. We have reform of physician payment, which is something I studied in my research for many years. We had this expanded bundle and then a quality assurance program that went along with it, and many others. So this highlights just the aspects of these policy initiatives that were bundles. A bunch of them have to do with that initial bundle, expanding the bundle, incorporating new technologies into the bundle. Those have all been hot issues that have affected the policy world in kidney disease. And then there's others that, sorry, I'm pressing the wrong button. Yeah, there's others that are more traditional value-based care in the way that we think about it now. Things like accountable care organizations for dialysis. There's and a lot of these are mandatory. This reforming payment for physicians, this ESRD quality incentive program that holds dialysis units accountable to quality measures. Unlike the value-based care in a lot of areas of medicine, in nephrology it's mandatory, which I think is probably where everywhere else is ultimately going, but it's just been going on for longer in nephrology. In 2020, these new payment models came out. These are like accountable care organizations for dialysis. And that came as a result of this Advancing American Health Kidney Initiative. And then most recently, actually starting this July, there's a new model coming out to increase the access to kidney transplants. So we've seen tons of value-based payment programs really trying to now shift the focus to controlling costs and controlling quality, because a lot of these programs have features in them that evaluate or pay for quality of care, as the governor was talking about. The idea is, rather than paying for quantity through fee-for-service, the policymakers will pay for quality, but then they also reward providers when they spend less on patients. And so that's sort of a lot of these newer programs with the basis behind them. You'll notice access isn't mentioned, and so I do think that's potential issue in these newer programs is are providers going to close and close shop in areas where they have less healthy populations and things like that. So I guess I got a little ahead of myself, but yeah, this is again this sort of triple aim: access, cost, and quality. Again, initially we had programs that were focusing on access and cutting costs. Concerns arose about quality. We had a whole bunch of these sort of quality initiatives to try to control and improve quality, but still pretty significant gaps in quality of care, which has now shifted us to the value-based payment programs that are trying to control costs and quality, but not explicitly addressing access. So if we look at everything I've discussed, passage of the ESRD program, improved access to care, efforts to expand access to home dialysis modalities and transplant have improved access to care. Bundled payment programs, efficiencies in dialysis delivery, newer value-based payment programs have been directed towards cost of care. And then national state quality initiatives, and more recently these value-based payment programs have been addressing quality. And so that's where we are now. There's a number of challenges that that policymakers, kidney care providers, patients that we face in trying to really tackle these three objectives. And some of these are unique to kidney disease, some of them not as unique. But one of the big ones is consolidation. So this is a figure from 2015 that shows DaVita and Fresenius, two large companies. If you add them both up, they're providing dialysis care for more than 2/3 of the entire population in the country of people getting dialysis. And that has actually, I think they've become even more concentrated since then. You have a couple of other smaller chains and independent providers. But these are among some of the most highly concentrated healthcare markets. I think the rest of healthcare has, since 2015, has caught up, and you now have hospital markets probably look like this, and skilled nursing facility markets might look like this. But dialysis has been concentrated in the way the hospitals are now for decades. The concern is that highly concentrated markets, I showed this through some of my research, and others have showed this, are associated with worse health outcomes. One of the things, especially when you have Medicare as the primary payer, you can't compete on price as much. And so I think maybe some of the facilities compete on things like quality. And so you have lower quality of care, worse health outcomes in these more concentrated markets. And then, I mentioned that if you have private health insurance, you get to keep that for 30 months. A lot of the competition for patients in dialysis comes for how do you get these private payer patients, as many of them as you can, because that's where all the profits come from. And what we have seen is some of these private insurance markets, these large chains are charging a lot more, up to 5-fold more than Medicare for dialysis in private insurance markets, and even Medicare Advantage. They're paying more for the chain. So I think concentrated markets have created a problem for quality. They create a problem for cost as well. The other big challenge has to do with movement to Medicare Advantage. Again, this is something that's happening, I think, more broadly in healthcare. It happened very quickly in dialysis. So it used to be that unless you had Medicare Advantage when you developed end-stage kidney disease, if you qualified for Medicare just because you had end-stage kidney disease, you couldn't go into Medicare Advantage. You had to go into traditional fee-for-service Medicare. All that changed with the 21st Century Cures Act, and in 2021, all of a sudden, anyone who has Medicare on dialysis can shift to Medicare Advantage if they want. So you saw this sharp increase in the use of Medicare Advantage. Actually, if you go into the more recent years, I think it's over 50% now of Medicare beneficiaries with end-stage kidney disease have Medicare Advantage. And this could be good. We heard about patients wanting choice in providers. This gives them choice. It gives them support with copays and things like that. The problem is, we just have no idea what this does for the quality of care, what kind of quality is being delivered to patients who are on Medicare Advantage. A lot of the mechanisms, the data, I mentioned there's large databases that have been used to monitor quality. That data is really scarce in Medicare Advantage. And so a lot of our tools for monitoring quality at the aggregate level, or even more granularly, aren't there with Medicare Advantage. So I think there's definitely challenges. Maybe some of this is is going to be good, but we have to see. And then finally, the Supreme Court 3 years ago basically made a ruling that could shift, or basically could. So they said that private insurers are allowed to not include any dialysis providers within their network if they want, certain types of private insurers. And so the concern is, if you're on dialysis, you have private insurance, and your insurer doesn't have any dialysis providers in their network, you're going to get rid of that private insurance and switch to Medicare. And we haven't seen a lot of that happen yet, but I think a lot of the insurance contracts might not be have been renegotiated since this ruling. But the concern is, if all the I mentioned private insurance is where a lot of the money is in dialysis. If that money goes away, what's going to happen to quality of care? I had a paper. Let me see. Yeah, it published 2 weeks ago. I just wanted to make sure it was published. But we looked at quality of care in private insurance, and found that there was some indication that some of these outcomes, like mortality, was higher in facilities that had less private insurance. There's definitely more work that needs to be done because there's a lot of potential confounders when you just do a cross-sectional comparison. But I think there's definitely concern about quality if the private insurers do end up, or patients end up having to give up their private insurance. And then finally, the last challenge, these bundled payment has been like a hallmark of the dialysis payment system. It's been tweaked, it's been added to, it's been modified. What about technology? How do you incorporate technology into a bundled payment system? This is a big issue because if you are developing a new dialysis technology, you know that no one's going to get paid more for delivering your technology. And so there's been very little innovation in the dialysis field. And now that the medications are incorporated in the bundle, there's been less interest in developing new medications also. And so the Health and Human Services tried about 5 years ago to create some pathways to incorporate new technologies into dialysis to encourage technological innovation. But at one extreme, you do that and you're basically getting rid of the bundle and all of the cost containment that you had from the bundle. So how do you balance that? And letting new technologies come in, paying for them, while also having a bundled payment system that controls costs. Devices have been another issue. New devices. So, for example, there's a new type of dialysis. There was a trial in New England Journal of Medicine a year or two ago that showed improved lower mortality with people getting this thing called hemodiafiltration. It's used in Europe. It's used in Asia. It's not being used here yet, and it would be expensive to bring it in. And so, it's something that improves mortality but is expensive. How do the policymakers incorporate that into the bundle? So, in conclusion. During its first 50 years, the U.S. End-Stage Renal Disease Program provided critical access to life-saving care for patients with kidney failure. The ESRD program underwent a series of reforms as policymakers aimed to control costs while maintaining quality and access to care. Challenges in balancing cost, quality, and access will persist as the program enters the next half-century of its existence. I wanted to say I started this by saying why is this all important to people in primary care. Again, I think it's just an interesting story, but I think we talked a lot about the cost, quality, and access, the balance of trying to achieve those. I think those same tensions play out in policy in all areas of healthcare, and so seeing it kind of so explicitly, the way it played out over the decades in nephrology is informative. I think there's some the government's role as a payer for healthcare, and the amount of regulation needed to enforce quality. This program, what's cause and effect, I don't know, but I think the sort of three broad trends of huge role of government in paying for healthcare, huge role in regulating. By current day, regulating almost all aspects of dialysis care, and a huge concentration in providers. What's causal? I think there's questions that need to be teased out because I think those could also become important in other areas of healthcare. Seeing those trends as pay for performance becomes more widely part of the payment system. And so then I think the last thing is just. A lot of what the policymakers had to respond to weren't things that you could have predicted. All of the controversy over the ESAs, EPO, and things like that, no one would have predicted in the 80s. Those came out in 1990. And so I think, just being open for, what we think are the policy challenges now might not necessarily be what we have to deal with in 10 years. So I think I'll stop there, answer any questions. Thank you.
What was the end goal of the initial program? I mean, we didn't want people to die from kidney failure, but we're not curing the disease, right? We're not stopping kidney failure, we're just extending it. So was there any thought given to an ultimate goal of, increasing kidney transplant programs? And that seemed to be the obvious idea, was to turn over from going from running people on dialysis to get them into kidney transplant. And what's happened with that transition?
Yeah, I think, if you look at discussions, if you look at that Gottschalk report, I didn't see it. I haven't seen a whole lot written about prevention of kidney failure. It really was trying to prevent people from dying of kidney failure through, and they were paying for transplants also. So it was through access to transplant, access to dialysis. I guess one of the first times that I've seen more what you're discussing was that Advancing American Kidney Health Initiative in 2019. It was an executive order by President Trump and HHS where they initiated all of these value-based payment programs. They had a whole bunch of other initiatives as part of it. There was an awareness campaign that giving CDC money to increase awareness of kidney disease, collecting data. There are all sorts of aspects of it. But if you look at sort of the executive summary or the introduction to the report that led to that, or that came with that initiative, was probably the first time I had seen, they were basically making the same criticism. They were saying, right now we pay for kidney failure, we need to pay for kidney health. And so a lot of the, in addition to these campaigns by the CDC and other organizations to raise awareness for chronic kidney disease as a way of preventing kidney failure, another unique aspect of this initiative, the models that came out, there were four sort of accountable care organization type models for dialysis. And what they did was before that there had been models for just dialysis. What this initiative did was they kind of did version 2.0 of these models, but they expanded it to patients with chronic kidney disease. And the idea was we need to extend value-based payment to chronic kidney disease and create incentives to prevent the end-stage kidney disease. And that was the first time we saw anything like that, focusing on chronic kidney disease, come out of these value-based payment models. But it's definitely a good point, and it's definitely a challenge. Patients don't have Medicare when they have chronic kidney disease necessarily, and so it's kind of tough. Medicare has a lot more control over what happens when patients go to ESRD and they're the primary payer. So I think it takes collaborating with Medicaid, private insurers, these awareness campaigns. A lot of patients don't know they have kidney disease until their kidneys fail. And so I think it's definitely really important to prevent it, but probably not something that just Medicare can fix by tweaking their payment. Yeah.
Yeah, so my question is about the cost of technology. In many industries, as the technology advances, the cost and the quality, the cost comes down and the quality goes up, like flat screen TVs. You bought one of those many, many years ago and it was very expensive. Now they're very inexpensive. It seems like in medicine it's just the opposite. As we advance technologically, costs increase. And I'm wondering why it's different, or if it is different in kidney dialysis, and what could be done with that, following the lead of other industries.
That's a good question. I agree. If you hear like politicians get up and talk, they all talk about, we can have the technology and the lower costs. And I just think there's not a whole lot of technological improvements that do that. Usually you improve life, you improve quality of life, you improve survival with innovations. But I think most innovations do cost more money. They could be cost effective in that it's a good value for the payment, but they do usually cost more. Why that isn't the case? Why is that the case with medicine versus televisions? The only thing I can think of is technology keeps progressing in medicine. So is one technology? So you saw with dialysis, the technology didn't change from 1972 or 1980 to now. The dialysis procedure is basically the same, but what happened is they got really good and efficient at providing dialysis. So despite those payments per procedure going down over 30 years, dialysis units, a lot of them were able to stay in business because over time they became really efficient at producing dialysis. And those types of efficiencies, maybe you need the same technology to be in place for 40 years to have those efficiencies. If you're developing new technologies every 5 or 10 years, no one ever has a chance to kind of catch up and do it efficiently. That's just one random thought that I had. But I do think, the fact that dialysis hadn't changed, what did happen with dialysis, people say, oh, nothing's changed, there's been no advancements. Well, there were advancements over those 40 years. It was advancements in efficiency. They had, it was one of the large dialysis organizations, the CEO was talking, and this caused a lot of controversy, but he talked, I think it was about producing dialysis as similar, running a dialysis company is similar to running a Taco Bell in terms of like the cookie cutter, just efficiency. And so I think there were advancements, but without technological innovation, it was advancements in efficiency. And maybe, again, that just takes longer to play out. Looks like I'm early. I may have talked too fast, but any other questions? All right. Sorry. Okay, yeah. Good.
Okay, I'm referring to my instructions.